Okay, so are we recording? Recording to start. Okay, perfect. Good morning, everyone. This is Ted Doolittle. I am with the Office of the Healthcare Advocate, State of Connecticut, and I'm the chair of the Health Equity Outreach and Consumer Experience Advisory Committee. Welcome to the special meeting of Thursday, October 27th. It is requested that participants introduce themselves every time they speak. Roll call votes will be taken for every action item, and the members of the Access Health staff will introduce themselves. With that, Marcin, I turn it over to you for a roll call.
For attendance, Theodore Doolittle.
Here.
TC Woods.
Here.
Deb Pollen.
Here.
Sheldon Tubman.
Here.
Evan Galvin.
Here.
Karen Siegel.
Here.
Giselle Carlotta McDonald.
Here.
Leslie Greer. I think somebody else is just joining us. So just give me a second. Okay. Holly Hackett.
Yes.
And Gerald O'Sullivan. Thank you. That concludes the introduction of the committee members.
Okay, thank you, Marcin. I know you said there's no public comment. Is that still the case? Is there a member of the public who joined who wishes to make a comment? If so, please identify yourself. Okay, hearing none, we're on to item C, which is review and approval of the minutes. For purposes of discussion, I'd like to solicit a motion to approve the September 22, 2022 Health Equity Outreach and Consumer Experience Advisory Committee special meeting minutes.
So moved, Deb Pollen.
Kevin Galvin.
Seconded, CC Woods, yes.
Moved by Deb Pollen, seconded by CC Woods. Any comments, questions, or suggestions? Hearing none, let's move to a voice vote. All those in favor of the motion, please signify by saying.
Sorry,
we
Mr.
have to do a
Chair,
roll
we have
call.
to.
Sorry,
roll
yeah,
call.
absolutely. Sorry, Marcin. Go ahead with the roll call then. Thanks.
Theodore Doolittle.
Aye.
TC Woods.
Yes.
Deb Pollen.
Yes.
Sheldon Tubman.
Yes.
Evan Galvin.
Yes.
Karen Siegel. Giselle Carlotta McDonald.
Yes.
Leslie Greer. And Holly Hackett.
Yes.
Thank you.
Thank you, Marcin. This brings us to item D. Welcome to Holly Hackett. Holly, it's great to have you here. I want you to introduce yourself to the committee, but first I will say that I have known Holly for several years. Holly's a community leader, very active in the Medicare for All movement here in Connecticut, as well as other initiatives. And it was terrific to have you recommended for membership. And I know that you were, I believe, unanimously confirmed just the other day as a new member. So thanks so much, Holly, for your willingness to serve. And if you care to, please tell us a little bit about yourself.
Sure. First, thank you so much, Ted. I appreciate the wonderful, glowing review. I am Holly Hackett. I am from East Haven originally, but most of the work and my heart goes into New Haven advocacy, as far also statewide now with Keep the Promise Coalition. I know a few of your faces, and I know Giselle. I sat next to her at a meeting earlier this week. So I am just happy to be a part of this board and to help further health equity, health justice. So thank you so much for having me.
Well, terrific, and warm greetings to you. And again, thanks for your willingness to serve in this capacity. That brings us to item E. If I'm not, well, before we move there, I would actually open the floor to anybody who wishes to greet Holly or say hi or comment, because some of us are not in person, and we would certainly be doing that in person. I don't want to lose that. I see that somebody made a comment in the chat. And so just open mic for just a moment for anybody who wishes to express themselves.
Good morning. This is James Michelle. I want to echo Ted's welcoming statement to you. We look forward to your contribution to this very important and very critical committee work that we do at Access Health. We look forward to your contribution as we continue to help address health disparities across the state of Connecticut, and disparities not just in terms of ethnic or race, but also economic disparities as well. Thank you for joining the board. We look forward to your contribution.
Thank you, James. Thank you. I appreciate it.
And this is Sheldon Taubman. I'd like to also welcome Holly. She really is a leader on issues of health disparities of all kinds. And she will, I'm sure, provide a lot of insight, including particularly what it's like as a consumer. Thank you.
Thank you, Sheldon.
I know several of you in the one-on-one meetings expressed a desire to get somebody with Holly's background and qualifications on. So hopefully this is responsive to some of the input from the committee. Thank you very much for that. Anybody else?
I'll jump in. I know I put it in the chat, but I'm so excited to see Holly in this committee. I've been, like Holly mentioned, in multiple different meetings with Holly, and I know anytime that she joins, her voice is extremely important. So I'm very, very happy that you're joining this effort. Welcome.
Thank you, Giselle.
Thanks, Giselle. Anybody else, or if not? Yep, go ahead.
Oh, did he say
Somebody was trying to jump in.
Oh,
Please
good
go ahead.
morning. Hi, Holly. Tammy Hendricks. I'm the Director of Health Equity and Outreach at Access Health. We are so lucky to have you. And I know your suggestions and feedback will be so important for us as we move forward. You know, my department focus is on health disparities and health equity. So thank you for taking the time out, and I look forward to working with you.
Thank you, Tammy, as do I. Thank you so much.
Great. All right, so that was a terrific item D. Welcome, Holly Hackett. We're on to item E, mission and vision of the committee. Seeking some committee feedback on this. I'm going to turn it over to Tammy Hendricks. Tammy, go ahead.
Yes. Good morning, everyone, again. So I wanted to revisit this slide. We did have it at the first meeting, but with Holly's, our new addition of Holly, I'd like to revisit it. You know, the committee goals, really our focus is health equity, expanding outreach, and improving the consumer experience. So I've included these three areas that I thought the committee would focus on, right? First, access, consumer access to health insurance. This is our mission at Access Health, reducing the rate of the uninsured and reducing health disparities. But the next two goals really are focused on expanding our reach in the communities and improving our outreach efforts. So right now, as you all know, we do extensive community outreach, but we're always looking for better ways to reach community partners and consumers alike, informing those and really collaborating with key partners as we move forward. So I'll open it up for any suggestions or have a discussion on these items if we want any changes, additions.
I had a thought about the first bullet, if that's okay. I'm looking at this and it's not clear to me if you would like us to stay focused on enrollment. Because when I think about health equity and access to equitable healthcare, I think also about benefit design, network adequacy, how networks are communicated to the consumer. So it read both ways to me, and I just wanted to clarify whether or not that's within the scope of this committee's discussion.
Yes.
Okay,
We do have the HPBQ. All right, that's the Health and Benefit, Qualification Committee.
yes,
Right.
yes, the other.
So, and any conversation coming out of this with respect to plan design, well, will be fed to that.
Okay,
So
perfect.
it's certainly incorporated into the discussion. That's what's on January for next year. So certainly, if we have thoughts about how things are designed, do we have to address health disparities? We should have them there. It was good to communicate them to the, so to that committee, but they start working in January.
So I can add like a sub bullet to kind of,
Plan designs.
yes,
Right.
kind of break it up.
Insurance and
Sure.
like being able to actually use your health insurance once
Right.
you're older too.
Yeah.
And we talked, you were here, I think, Karen, at the last meeting. We talked at the last meeting about the essential community providers, our requirement and how they're, incorporated in the carrier networks. So that ties into, I think, what you're thinking of.
A lot of recent work done in other states and SDN, as there has been in Connecticut, but in different spaces or specifically around thinking about how cultural competence is communicated,
Right.
consumers through network. I always forget what those are called, the portals where you can look up a doctor.
The provider directory.
Directory. And there also has been a lot of benefit design work related to equity in a
Right.
couple of other states.
Right.
I just think those are things worth discussing.
Absolutely. I think one of the areas that we're going to focus on over the next several years is how do we get everybody to sign up, have a provider, have a family doctor, the old language, and also get them to go see the doctor at least once a year. I think that'll go along with to help address health disparities. If we ensure that everyone has a doctor for their family, for themselves and their family, then they see them at least once a year. That's going to require a lot of aggressive outreach and marketing on our part to make that happen. Right?
It looks like Holly has a question or a comment, and we'll recognize her. I did want to mention, those of you in the room, I recognize most of your voices, but some of the new committee members might not. That was a discussion, including Karen, Susan Rich By, and James Michelle. But if you could just, if you're in the room, preface your comments with getting us the name that goes with the voice, that'd be wonderful. But Holly, go ahead.
Thank you so much. So my comment and or question is, as far as expanding community partnerships, not so much on the provider side, but more so on the side of the consumer. I hate that word, by the way. Do you reach out to disability access, people in the disability communities as well? Because those of us who work often get kicked off of a lot of programs because of the disgusting benefits cliff we have here in Connecticut. So that might be an option to consider branching out to for outreach. And going back to what James said is to try to get everyone to go to a family doctor. I think your efforts have to also be to put everything that you have in plain language, because people who have learning differences, such as myself, don't always understand, although I've been in the healthcare world for so long now that I do understand most of the language. But when you have people who have learning differences or English is not their first language, they are not going to understand a lot of the language that is in the outreach material and the community outreach things that you guys put out there. Sometimes the language is not good. Like, it is way too high over people's heads for people to understand what you're saying. And I will say that a lot of people in the community, James, don't realize that they can go see their doctor for a physical or something like that without having it go to their spend down. Even though it's been widely said, they don't believe it. So you have to break that whole stigma there, that they can go see their doctor because it's preventative or something like that. So that's a huge thing that I've seen in the community, where they don't understand the language that is written on the materials they are given, so they don't know what anything means.
So Holly, I appreciate those comments about the folks not knowing that you go see a doctor for your preventative services free of no cost to you. So that's one issue. The other
Yeah.
one is a lot of folks grow up in environments where that was not the norm when they were growing up. Right?
Correct.
That was not the norm. So the parents, grandparents didn't do it. So our challenge is to get into those communities in front of them, not through mass media, although we will do some of that as well. But working with our community partners, literally dragging them to see a doctor if we need to do that. So we got to change those behaviors, introduce new behaviors and change them. So that's not going to be easy, but we're going to be consistent in applying that pressure. So we think it does two things. Number one, it helps us to address health disparities by getting people to help their need as early as possible. And it would also have an impact on the cost of healthcare across the state of Connecticut, as people get picked up early in preventative
No doubt.
services, and they get addressed early rather than when they have an acute care situation, medical situation, where it can be very expensive. So we think that's a win-win. So that's something that we are developing a strategy within Access Health to do this outreach, consistent multi-year approach. This will involve everybody, not just us, but it involve the carriers, hospitals, as well as our community partners. So we are working on developing that strategy. We'll bring it back to this committee as we develop it to get your input.
Okay, great. And again, I caution you, please, whatever pamphlets, flyers you put out there, plain language. It is really, really important, more so than you really realize. So, and that is something that I'm going to stick to on everything from here on out, because it really, really makes a difference in people and able to reach people who have disabilities and you know, so I'm that's really going to be a sticking point for me.
Yes, Holly, to add to that, we do
Yes.
recognize that
Who is
outreach-
speaking, please?
Oh, I'm sorry, it's Tammy Hendricks.
Gotcha. Thanks, Tim.
I'm sorry about that. So yes, Holly, we see that every day in outreach. So that's why our focus really is on in-person outreach, so that we don't only send out these pamphlets and flyers where they're talking to consumers and explaining things as best as we can. But that is something that we are going to work on. And I've had discussions with our marketing director on that, the wording of the flyers and how to simplify things and make it more, so we see that every day, and I totally agree with you. It's something that we're actively working on. And as far as the language, we always in outreach at least have English and Spanish for every single pamphlet or flyer that we do. Sometimes Polish. This year we've incorporated more Polish translations, but we also we recognize the need to have our pamphlets and flyers in different languages as well. So completely agree with you. It's on my list too. And thank you for that feedback.
I want to make a comment here. First, thanks very much for the question and the answer. It is always a struggle to make sure that the language is plain. There's a statute that was passed in the last session that enhances the prominence of the already required notification on claim denials about my office. Right now, the carriers are required to put our name and address, but it winds up in 9-point type back near the alternative languages sometimes. And under the new regime that's going to go into effect on January 1st, that's going to be in a call out box on the front page in language that my office approves. And I just want to, I'm raising it because I just want to share with you, one of the attorneys in my office made the great suggestion that the first words in that call out box should be, "This is a denial," right? Because often you get this letter, you can't figure out what the heck is going on. And so we really need to continue to be sensitive to that. The other thing I wanted to raise is, James, you and I, in the past, have had discussions about a concept that you have been thinking about, or were thinking about a couple of years ago, about trying to connect folks with a primary care provider during or immediately after the enrollment process. Are you still thinking of that type of initiative, which I think would be kind of cutting edge? I haven't heard another state doing it, but I just wanted you to kind of talk about that and update us on thinking around
Sure.
anything like that.
Well, Ted, that's what I was referring to earlier when I mentioned making sure everyone has a primary care or family doctor, but more importantly, making sure they at least see that doctor at least once a year. And this is why the Broker Academy was so important for us, because typically the brokers, we expect them to do some follow-up with their customers. I know Holly doesn't like that name, customers, but to have the brokers follow up with their clients to ensure that they're at least seeing that they're taking full advantage of all of the benefits the plan provides for them. But Ted, to your point, that's the approach we're going to use to achieve what you and I have talked about in the past, is to have a sustained campaign, working with the carriers, and also doing our direct outreach to all of our customers to ensure that they have a doctor in their network that's going to manage them and their family's health, as well as making sure they schedule the very first medical appointment to have a physical for themselves and their entire family as early as possible. So that's a strategy we are pursuing. And now that we have the tools available, we have the brokers in the communities that are particularly challenging. So we're gonna pursue that before due speed. But once the strategy is up and running, once we have strategy documented, we'll come back to this committee to get your input. Then we'll present it to our board. Then we'll start executing.
Yeah, okay, great. Thanks, James. It would be wonderful if, before you went out to the carriers, you sought the input of this organization, this committee here, because I think folks would be really excited to give you guys some feedback that I bet would be pretty valuable. I see Giselle. Sorry, James, go ahead.
I would say a lot of the carriers have their own efforts in place and trying to get all of their members pick, but it's not required. In some plans it is, but most of the plans do not require it. So I just want to find out what they're doing before we
Gotcha.
start the own strategy. That's all.
Yeah, that makes sense. As long as we're talking about making sure we get this committee's input before our strategy is fully baked, that's wonderful. Thanks, James. Giselle, go ahead.
Thank you. And actually, the comment, James, that you just made kind of continues what I was thinking in terms of that navigation role. So at Project Access, we focus on access to care. So what you're sharing about making sure that someone, when they do have insurance, making sure that now they can get the health care that they need. So being connected with primary care or urgent, if they have specialty care needs. So to me, that triggers that, like the services that we provide of navigation. So we, as most of you might know, we've been a navigator for Access Health, and to me, that navigator, I always struggle understanding the difference between being an outreach navigator than actually doing the navigation. So connecting individuals that have barriers to access to care once they become insured and getting them connected to either primary care or specialty care. As I continue to see the goals in front of me, I'm thinking too of what Karen mentioned of that enrollment. Are we talking about outreach, providing information, disseminating information about what's coming, open enrollment? Do you know that you actually may qualify for insurance, all of that? Or are we also, the goal is that we are supporting enrollment during the enrollment periods? Is that part of what we want, what we need from the community to also help with enrollment? So I'm thinking of three different buckets as I see the three in front of me: the outreach effort, the enrollment effort, and then the navigation effort of getting people connected. So outreach to those that don't have the information, enrollment to those that need help getting enrolled because they might need someone to sit with them, to actually fill out the forms, to understand the language like Holly was highlighting, and then actually navigating to get connected. So those three big strategies, and is that something that this committee can help with each one to make sure that we're addressing all the barriers that we're seeing?
So
Yeah.
if I can kind of try to knit together what Karen was suggesting and Giselle's comments and some of the other comments, it sounds like folks and wanted Tammy to get input after I make my comment here. So it sounds to me like the committee might be interested in drilling down a little bit more on the general topic of outreach efforts. I'm not hearing anybody saying outreach effort shouldn't be a key goal. I'm hearing people say, let's specify within that bucket some priorities. Is that, have I mischaracterized a committee member on that? Okay. So Tammy, there's a little bit of guidance for you to react to. We do have a few more minutes on this topic. So Tammy or anybody on the staff who wants to react, please go ahead.
Yes, Giselle, thank you for that feedback. So those three areas that you mentioned basically fit in the three areas that we have on the slides, but I need to hone in more on each part. So that's what I'll do. And then we can go from there. So I'll add more specific bullet points on what we should focus on, and that will help us keep the straight and narrow when we have discussion. So thank you for that feedback. And yes, your 3 points do fit into these, but they're more specific. So I'll work on this.
So it sounds like high level. I wasn't hearing anybody say that that we need to add a fourth goal or that one of these goals needs to be changed. Rather,
if we're going to dig down, particularly on primary care and navigation, I think that could be a great conversation here because it brings in some of the reasons why that navigation support is so important too, not just the connection itself, but for example, is the primary care provider's office ADA compliant? Can you physically get into it? How are you treated when you're there? Is the care culturally and linguistically appropriate? And I think that that from an equity perspective, it's both the outreach piece and the experience of the care piece that are really important in that context. So just, you know, if we're planning for future conversation, I just wanted to throw that out there for consideration.
Thanks, Karen. Let me just, in light of all this really good discussion, if we look at the first goal, improve consumer access to health insurance, are we really talking though more not just about the insurance, but also access to health care or to you know, using the insurance benefits? I wonder if that's a tweak to the language of that goal that we want to consider. Throwing it out there.
And this is Susan Richby, and if I could piggyback on that, Ted, one of our goals for this OE, one of my goals specifically managing the plan management department, is really focusing our outreach messaging on the benefits in our plans so that consumers understand, as James has pointed out, preventative care has no cost sharing. And nearly all of our standard plans, I think, except the Bronze HSA, you can go to the primary care, you can go to the specialty doctor, you can have labs, you can access generic drugs with just the copay. There's no, people get into this discussion about the deductible and I can't access any care under this plan, and that's totally not correct. But I think consumers just don't understand how the plans work. So I think one of my goals for this year is to really work on the communication of that, which I think ties into what Karen's talking about and Giselle as well, that so that people actually understand the benefits once they buy a plan, or hopefully with a broker before they pick a plan, understand that, wow, I can really go to the doctor with this plan. It's not, don't look at that deductible number and think, okay, I can't afford that. I can't go, I can't do anything. So I think that's a really key message for us as well, and very much tying into health equity, to make sure that the care is accessible for people.
Right.
Yeah, maybe one way to crystallize this in a few words is we at OHA sometimes talk about helping our clients maximize their benefits, right? Maximization of benefits. Maybe that is something that should find its way into these committee goals, which are solid and good, but obviously we don't want this in terms of having focus on enrollment. We don't want this page to get too busy, right? But we want to understand what is behind each of these three buckets. But the concept of maximizing benefits might be a way to capture some of what this committee is concerned about.
So just to sum up what I think I heard. So for the first bucket, we really want to focus on enrollment, utilization, maximizing the benefits, health literacy, right? Does that all fit into that first bucket of improving consumer access to health insurance to start?
I would say so.
This is Deb Poland. I think that does go beyond access to health insurance, and we might change it or add in the words healthcare.
Okay.
Yeah, this is Karen. I was just going to say almost exactly the same thing. I think if you want to add the network adequacy and benefit design pieces to it, healthcare, it's not health insurance.
Yeah. Thank you. Okay, so I will rework some of these, all of these bullet points, and we can put that up for discussion at the next meeting.
Wonderful. Thanks so much, Tammy. Really appreciate it. It's a good crystallization, and I think with this input, we'll improve it even further. So thank you so much. I think that brings us to item F, which is open enrollment outreach. And Tammy and Susan Rich-By are going to explain the open enrollment outreach that is upon us now, in fact. Go ahead.
Yes. Thank you. So moving on to open enrollment, this is the fun time of the year for the outreach team. We have a really robust open enrollment plan this year. So starting with our enrollment locations, we have 2 enrollment locations, one in East Hartford, one in Stamford. Locations are open normal business hours, typically from 9 to 5 or 10 to 6, Monday through Fridays. Then we supplement that with enrollment fairs. These are pop-up locations that we have throughout the state. We have 21 fairs that we have planned for this open enrollment. And this is significant because it's more than double what we did last year. COVID really, halted a lot of our in-person enrollment opportunities. So we're picking that back up this year. And what's important about the enrollment fairs is we base the locations off of data from the PHE extension. So we worked with our data analytics team. We know where the users on the PHE extensions are located. So we are targeting those areas for enrollment fairs and locations to make sure we reach a lot of those consumers. What was that? Oh, and so the PHE unwind is the public health emergency is possibly coming to an end for those who don't know what the PHE is. And Susan will get into that a little bit after I complete my my presentation. So we're really targeting those areas that have a high amount of people on the public health emergency extension, right? So once that extension ends, we are going to have to redetermine, DFS will have to redetermine those users, and there's a possibility that they'll need and qualify for a qualified health plan through Access Health. So we want to make sure we're in those areas. and reaching out to those consumers and community partners alike. Then we have our navigator programs, our navigator locations, right? We have 4 navigators this year. We doubled the program from last year. So community renewal team is back in Hartford. We've partnered this year with Community Health Center Association of Connecticut. They have various locations that have CAC, Certified Application Counselors, that can enroll folks. But also that ties into the navigator end of providing the service, right? Once individuals are enrolled, they can go to the centers to get care. We have the Greater Bridgeport Area Prevention Program in Bridgeport, and we have new opportunities in Waterbury. They also cover the Torrington area. So important, just in general, we are covering the state this year. Every county will have an in-person enrollment opportunity or a location that they can walk into and get enrollment help. So we're making sure that, you know, consumers have the option to not only go online, they call our call center, but they can see someone in person to get that enrollment help. And then I'll turn it over to Susan to give a quick update about Covered Connecticut and the public health emergency.
Thank you, Tammy. Susan Rich-By, Director of Legal and Governmental Affairs. So to kind of take us a step back, we all in this industry throw around PHE, stands for, as Tammy said, the public health emergency. This started at the beginning of the pandemic in 2020. And one of the things that happened in the legislation was the federal government wanted to ensure that people were not losing health coverage at this time. So they did not want people on Medicaid to lose, who were on Medicaid to lose coverage if they maybe became ineligible for Medicaid. So they created a Medicaid, now I'm going to forget the MOE, now I'm going to forget what the acronym stands for, but thank you, to extend the coverage. And so what this means is nobody is terminated because their income changes and they become ineligible. So the system is actually still processing the redeterminations, but nobody has been cut off. And the population that has not been cut off, but we've received data back that they aren't eligible right now, is just slightly over 400,000 people. So this has grown, you know, over the last 3 years that this has been in place. Now, the public health emergency right now is going to go through January, mid-January. On October 13th, HHS announced a 90-day renewal of the public health emergency, and the federal government has promised states, because of the importance of states' work on Medicaid in this, that they would give states 60 days notice so states can prepare. Now, obviously, states have been preparing for the whole 3 years, but to really know, okay, now it's really happening. So the next date that we need to watch is mid-November for mid-January. The rumors we hear is that this will probably be the last extension, but we won't know for certain for a few more weeks. But we have actively been working with the Department of Social Services. Obviously, they are taking the lead for this, but we've been working actively with them the whole entire time. There are changes that have to be made in our system every month for all of this. And there's really detailed planning going on now for what this is going to mean in January. So we are planning, you know, the unwind schedule, and Connecticut has said it will take full advantage of the 12 months permitted for the unwind, and we'll stagger that over the 12 months. We'll have pretty much the same volume, I believe, in each month of that. And I think I have to check with the Department of Social Services, but I think the strategy will be sort of the first people extended will be the first people that go through these new redeterminations with the potential, you know, to be terminated if they're not eligible. There's a big campaign going on making sure that consumers have updated their information with us, their contact information. We know that's key to make sure that we can reach people with these messages. And on our end, we are working with our call center because we know there's going to be greatly increased volume of calls to the call center when this happens, so that they are prepared with staffing. They normally staff down a little bit after our open enrollment period ends mid-January, but obviously with the public health emergency potentially ending around that time, they will keep up their staffing levels so that we are prepared for that. On the QHP end, we have also deferred taking any action on QHP consumers who have open verification items. We still send all the notices and really encourage consumers to verify, to submit information, especially where it pertains to their income and their eligibility for the tax credits, because that has a real-time tax ramification for them, but we haven't taken any action to terminate financial assistance or coverage during that time. So that will also ramp up when that happens as well. And another item that we wanted to talk about today that really ties in very closely with the end of the public health emergency is the Covered Connecticut program. And it's our hope that this will really provide a soft landing place for those who may not be eligible for Medicaid any longer and may be moving into eligibility for a QHP with financial assistance. So the Covered Connecticut program is for those who are ineligible for Medicaid for purposes of income, up to 175% of the federal poverty level. These are still, low income consumers. And this program was created by the state in 2021 to provide access to affordable coverage. So it is at no cost for the consumers that are in the program. They enroll in the Silver Qualified Health Plan with us, a cost sharing reduction plan at that income level, which greatly helps as well. They have the tax credit, and then the state pays the consumer portion of premium after the tax credit and also pays the consumer portion of cost sharing. So if they go to the doctor, they go to the hospital, prescription drugs, there's no cost sharing for them at all. It's paid either by the plan or by the state of Connecticut. So we've been working very closely. The program is now administered by the Department of Social Services, and also OHS was the original administrator of their program. We've been working very closely with both of those agencies on it since 2021. We've done a lot of communication over this period of time. Right now, there are currently nearly 12,000 people enrolled in Covered Connecticut, and Access Health has created a continuing special enrollment period for Covered Connecticut. Just like Medicaid and CHIP, it's ongoing throughout the year. There's no open enrollment period that they have to meet a time frame. Anytime they come in, if they're eligible, their coverage will start in the program the beginning of the next month. So Access Health has also worked on a lot of outreach on the program. And just to give you some recent updates, in mid-September, we sent communication on Covered Connecticut to 44,000 people from our system records that are not in the program, but given information we have, we feel could be potentially eligible. These were sent out through paper mail and email. And an interesting and positive statistic that I got from the marketing department this morning is that we're seeing very high open rates for those emails, which is really important. You send a lot of email, you don't know if people open it. We can tell who opens it. Normally, you have a 20% open rate on emails that you send out like this. We've been seeing a 40 to 50% open rate, which is very good. So people are actually seeing the message. Also, Tammy's team has been working on the outreach part, and they held 6 enrollment fairs over the summer from July through September in Norwich, Hartford, Bridgeport, New Haven, Waterbury, and Torrington. Hopefully I got that right, Tammy. And we've used geo-targeting to drive attendance to those fairs. So looking at who we know might be eligible, who's in the Norwich area, and making sure that they're aware that there's an enrollment fair to come out. So really using the locations instead of just kind of mass media, if you will. And another interesting and positive statistic that I got this morning was that Covered Connecticut is one of our top search queries within our knowledge base on our website, which is really important, which means, as we see, people are getting the emails, they're looking and they're coming to the website and they're looking up information about the program, which is really key, to increase that knowledge of the program. And for those that may know, as part of the legislation to create the program, the state required that DSS apply for a waiver, a Section 1115 waiver, to try to get federal cost sharing with the state on the program. The waiver was filed, I think, in April, and there have been communications back and forth with CMS, and they actually just received some positive communication just last week. So it seems very good and moving along. This is, I think, a first in kind. It's similar to what Massachusetts does with its a program that they have in their state, but I think this is the first instance of a state, doing something quite like this and applying for a waiver. So I'll pause if anyone has any questions.
That's all great information, Susan. Thanks. Sheldon, I know this is near and dear to your heart, and in fact, you might be involved in some litigation on this. You did put a comment in the chat. Do you want to briefly share that thought, please?
Sure. Thanks. First of all, thank you very much for the presentation. Yeah, on the public health emergency, what I said in the chat, you kind of overstated it. It's not true that nobody's been cut off on Medicaid during the public health emergency, and there's two reasons for that. The first, I guess you weren't at the meeting last time where I presented about the lawsuit, so I'll quickly talk about that too. But basically, the Families First Coronavirus Response Act, we call it the Coronavirus Response Act, is the law you're talking about, which said that during the public health emergency, and Congress did make the determination they didn't want people cut off Medicaid during this emergency, but the statute itself had two exceptions. One was people who move out of the jurisdiction, and the second is people who voluntarily go off of benefits. That was interpreted right away by CMS to mean what it says, but they also added in a reasonable additional one, which is that moving out of the district includes people who have died. So those were, I think people would agree with that. Everybody agreed on that. And CMS was very, very clear that other than those two exceptions, it is the way you described. However, the Trump administration, on its way out the door, issued a regulation in what's called an interim final rule. And in this interim final rule, they immediately, without going through the normal notice and comment process, invented new exceptions, major new exceptions. So one of the things I put in the chat was just about one of the exceptions. There's, according to DSS's data, which formal data in response to FOIA, which is now on file with the court, as of late August of this year, 11,500 people had already been cut off of Medicaid because of one of these exceptions. That was just the exception for people who are elderly or disabled and on Medicare. They have lost their Medicaid, and according to the data, they produce a chart every month. It's a few hundred people are losing their benefits. That's just one exception. Another exception is people who are legally present, have lawful status, but have been here less than 5 years, and therefore under the 5-year Medicaid bar would normally not be entitled to Medicaid. But most states have accepted an option to cover pregnant people and children during the 5-year bar. Another thing the Trump administration did in their this rule they produced in November of 2020 was to say, well, yeah, cut those people off when they turn 21 or are no longer pregnant and past the postpartum period. So that 11,500 figure is just for one exception, and we did ask for figures on the others. We don't know how many, and they said they didn't know. They didn't have good data on it. But you got to figure, and every month it's several hundred more people. So 15, 20, 25,000. We don't know how many. A lot of people have lost Medicaid during the public health emergency, unfortunately. And the lawsuit, for which there was a hearing before a federal judge yesterday on a motion for a preliminary injunction, challenges the legality of what the Trump administration did. And lastly, I'm sorry to go on for so long, but I thought since it was said that nobody's been cut off, and it's not true, the Biden administration did something good. on this, and that is on September 27th, they issued a notice stating that they're considering rescinding that Trump rule. And they're considering requiring all the states, and what they said is they're considering requiring the states to give an opportunity for people who have been cut off this way to re-enroll. Our request in the lawsuit is that, but just turn people on automatically, because it's going to be, if you expect notices to go out, they have to produce the notices, some will never get there, people won't respond, then DSS, which is already overworked, is going to have to process them. Just turn people back on. It's not that complicated. And so they've asked for comments by today. Today's, if anybody wants to file comments, you've got to get your comments in by the end of today, midnight. And of course, we're urging people to support what CMS is doing, except that we're urging them to say, do it immediately, not months from now, but do it immediately and turn everybody on automatically. Okay, now that I've done that long-winded thing, I have a question, if I may. When you said that you are focusing on places where, the things Tammy said this, but you're focusing on places where there's a lot of people who are on the extension. That is to say, there, it's roughly the figures we were given is 42% of folks on Magi Medicaid are on because of the extension, which is a huge number. It's good that you have data that's that specific about where they are, but I'm curious why. I mean, why would it be concentrated in particular places? And the two kinds of situations where somebody's on the extension are, first, they just never returned the paperwork, right? They were supposed to have done the redet and they didn't do it. And so with the exception of the exceptions, they're kept on anyway. And then the other group is people who are, they do the paperwork, but it's found that, yeah, after you submit your paperwork, it appears that you're not eligible, right? But you still are kept on unless one of those exceptions applies. And I guess my question is, why would that be in specific areas? It seems that would be more or less a random situation. Does that make any sense? Does the question make sense?
Sheldon, I heard you, Sheldon. As you know, we don't have, well, we have limited resources in terms of doing outreach. But more importantly, these are folks that we know where they live. So we're trying to concentrate our resources in the areas we think will be most impactful to the people who may lose coverage. So in the outreach we're gonna do, the in-person outreach is going to be in places where that has the highest concentration of the 400,000. Right? Because we know, like you said, they get the notices, they don't respond to the notice, they don't react, or for whatever reason. That's why we want to have a presence there to answer the questions, and most of the presence in person will be working through community-based organizations, where most of those impacted would be going to for help and guidance. Now, Sheldon, one of the areas that we want to, or one of the concerns that we have that we want to avoid or minimize, is that someone who currently is on Medicaid and may have a chronic illness, may be on a maintenance drug because of communication or lack thereof, and they don't know that they no longer have Medicaid. And the first time they find out that they have no Medicaid is when they go to the doctor or go to fill a prescription. So we're trying to avoid that by being in person in those communities where that has the highest number of folks who may lose coverage as a result of the redetermination. And again, 400,000, we know where they are. We have very specific information about their last known address. We know the community organizations they may have enrolled through. So that's our strategy. And again, if we had unlimited amount of resources, then we'd cover the whole state. So given our limited resources, we have to be targeted on where we do the outreach to ensure we reach the greatest amount of people who may be impacted. So that's our thought process in coming up with that strategy.
And
Thank
I'd
you.
like to add one point to that. We found that these areas overlap with areas that have historically higher uninsured rates. So that also adds into why we are targeting these areas as well. They have been known to have high need, higher uninsured rates. So it makes it even more meaningful for us to be in these areas.
I appreciate the answers very much. My question though was actually a little different. My question was why? And why do we have any thoughts as to why that is occurring in concentrated areas? And maybe your last statement sort of does hint at it, that it's sort of like you see that in high uninsurance. But I mean, I guess you could say there are certain areas where people are more likely not to respond to the mail. More, some communities where people are, well, there could be, literacy issues, obviously, that could be a factor. But that's what I was really asking about. If you had and what you laid out makes a lot of sense. And I totally get the limited resources. That's why you're concentrating where the higher incidence, which totally makes sense. I'm just trying to understand, why that would not be random. Why is it concentrated in certain places?
Okay, well, if I think Tammy's answer did hint at it for sure, that we also see that concentration in uninsured. If you have further thoughts on that from the staff, why don't we go ahead and pursue that, disseminate that through an email or something like that. It is good to know that we know where they are, and therefore just operationally we're going to concentrate on them. I think that's important. Sheldon, I think I'm going to go ahead and move to Holly, if that's okay.
Thank you very much. I really appreciate the answer.
All right, Holly, go ahead.
So I actually can answer from a consumer point of view, to be quite honest with you. I don't reply to those emails because DSS never changes my information, ever, ever, ever. I have done it twice now through Inc., and I have done it 4 times online, and not once when I get my paperwork back does it ever, sorry, I'm yelling because it's annoying as all get out, have they ever changed any of the information that I have changed. So here comes my passion, and that's when I get loud. For those of you who don't know me, it is not anger toward you or disrespect. It is my passion. So that's the answer. I am not going to open this freaking mail that's about this thick and take my time, which is difficult for me because I've had 6 brain surgeries. Also, for those of you who don't know me, to fill out every piece of paper front and back and take it painstakingly and do this it's hard for me, and send it back and then get a whole nother thing, not 3 months later, to do it all over that they've never received it. I'm not going to do that. I'm tired of it. And so I do it online, and I've done it 4 times. It has never changed. So I'm quite annoyed to the nth degree. And if I get kicked off, so be it. I have Sheldon for that, but I have tried my best to do this and to update it and to take care of everything I needed to, and it never changes. I'm sorry. I understand there's a lack of this and that and yada yada, but you know what? If I didn't do my job, I wouldn't have it.
Any thoughts from staff? I did put in the margin in the chat. I did put a link to a study out of California that showed that adding an extra resource intensive step of a phone call to emails really significantly helps with this process. But thank you for sharing those really real frustrations, Holly. Any thoughts from staff or anybody else in response?
So this was I just to understand, Holly, this was, what application were you referring to? I'm sorry.
Oh, for redetermination.
Okay.
mean, this is Karen. I just want to chime in and say this is something that came up all the time when we used to have the Covering Connecticut's Kids and Families meetings on a quarterly basis, that there are some glitches in the back end of the system where people try to update their information and it doesn't go through. You have two logins for two completely different systems. Knowing which one you're being directed to is nearly impossible. So I think this goes back to some of what Giselle was saying about how we work some navigation support into the process, and it's maybe something at a later time. And at the risk of, Ted, with your permission, I also had an unrelated question that I hope is a quick one. I can
Go
show
ahead.
that from.
Go ahead.
I'm wondering if there is a plan or could be a plan for reporting on utilization, particularly of the wraparound services for Covered Connecticut, to give an indicator of whether or not efforts to inform people about their benefits is reaching people. Somewhere down the line, particularly in a new program, it would be nice to have just a benchmark to look at.
I think DSS may have that information. We don't have access to that level of information. That's
Okay.
about claims processing, and the carriers have it. Since DSS is paying for it, DSS may have access to it.
Okay.
But we don't have access to that. So that might be a DSS question.
Or maybe it's something we could coordinate, because it seems like it would be useful for you all to know whether or not people are using the information you're giving them to access the benefit, right?
I guess it would actually with HIPAA requirements, sharing information of people who's paying claims for whom, it's a little dicey. So, but we'll go back and look at it, see whether we can get access to that information. But I know the carriers in DSS, we certainly have that. DSS is paying,
Right.
they're paying part of the cost,
Right.
right? And they're paying the premium cost and co-sharing, so that'll be an indicator of how people are going. But we don't have access to any of that information. Whether we can get to it, that's a question that we have to work with our legal team.
Right.
See whether or not if with this valid HIPAA.
Well, if it's aggregated.
Or aggregated, yeah, maybe there's some aggregated to see if there are trends.
But no,
People are using the coverage.
DSS already has that information.
Yeah.
So to have another person playing in that sandbox could make things even more complicated.
Yeah, I think what James is saying is, I don't know if you brought that up.
I have.
Okay.
Brought it up with legislators. Like, I think if we want to think about the consumer experience, we need to be looking at
Right.
our utilization trends the same or similar, so
Right.
that we know whether or not people are really leveraging this in the way that was intended.
Right.
Thanks for that discussion. I just want to follow up a little bit on Holly's point. So we have here a consumer who multiple times has inputted her information. It hasn't been reflected. Are we seeing other folks come to us with that complaint? And also, what should we do with that complaint? Question to the staff. Is that something that we need to be raising with DSS or with the DSS vendor? I'm not sure. If it's not an Access Health fix, where is the fix, and can Access Health reach out to make an inquiry about this?
So Ted, I don't know. This sounds like this is exclusively to DSS challenge, not Access Health. So I'm not so sure we could be of any help in this space. This is a access. We don't have any connection at all to what Holly was just describing. When you go online in our system, you update the information. The update is automatic and instantly, right? So what Holly was just describing, we can't comment on it because we have no idea what's going on behind the scenes with DSS's system. Could we not have access to it? We don't engage in it.
That's fair. Let me suggest this, Holly. Why don't you and I get together offline, okay? And perhaps you and I do a joint letter to DSS to raise this issue. Obviously, it's an important issue. If it's happening to you, it's happening to others. Sheldon, do you have a comment on that? And then I see Holly was preparing to make a comment too. Let's go to Sheldon first, Holly, and then you, because I saw Sheldon's hand first. Go ahead, Sheldon.
Yeah, I just wanted to raise a question and write it in light of James' response and, explaining the different systems that's over DSS land. And I understand Access Health has no control over it. It's just a sort of a question, like a jurisdictional question, whether people think this committee should have some jurisdiction it sounds like it doesn't, and and just asking the question, should it have some jurisdiction over consumer, I know how doesn't like that word, consumer access issues, access issues where, it's a combined system, right? I mean, it's integrated to some degree. Access Health and DSS are together running Magi Medicaid plus Covered Connecticut. So is this a thing where it would make sense for the jurisdictions committee to include those kinds of things, even though, as James correctly said, that nobody at Access Health can control any of that. It's all at DSS. But, and just a thought, you could say, well, we want DSS to be at these meetings ex officio, somebody, somebody who knows this stuff ex officio. And we want to engage DSS because, part of the, like obviously Holly's example, but others, it's really not Access Health who can control it. And so instead of just being powerless and saying, well, we can't do anything about it because it's not out of control, I mean, as a group, we could say, well, let's engage with them.
Yeah.
So I'm just, I don't know if that's the right answer, but I just want to suggest.
Yeah,
that.
well, certainly, I think maybe a DSS liaison is probably, a reasonable request for us to ask for a DSS liaison to this committee. I won't ask for a response from staff on that suggestion right now. You guys can think about it, but please do think about it and get back to us. And I see Holly has been itching to get in, so please go ahead.
Yeah,
So-
can I add one comment, one suggestion to what was suggested in that these DSS exclusive issues, can we create a different form? Because what I would hate is for this committee to get tied down Medicaid exclusively Medicaid issues, and then we kind of start excluding or forget about other areas that we are established for. All right, so can we create a committee specifically just to discuss about DSS challenges?
Okay.
Rather
Okay.
than
I don't want to decide this right now, but I want staff and committee members to think about this, and perhaps we can discuss it further at the next meeting, whether or not it does make sense to ask for an ad hoc or ex officio liaison. Again, I don't want to resolve it one way or another right now. Go ahead, Holly.
So my point was, okay, granted, you're saying that you guys are separate, okay? So, but, all right, and keep in mind, issue here sometimes, but I did hear you say that you were told basically by DSS where the concentration of everyone was. So you're not completely separated. So if I was redetermined to not be eligible for benefits, then perhaps I would come see Access Health. You understand what I'm saying as a consumer? So had I not been, if they actually did my redetermination, then I would know whether or not I was eligible for an Access Health plan, or if, do you understand what I'm trying to get at here? And that's kind of my point too, is if that's my point. Sorry.
So I think we need to have further discussion about this, Holly. It's a great point. In the meantime, in terms of trying to take action this month, let's you and I talk, and maybe we do a joint letter to DSS on this particular issue. But let's continue to think about the broader issue of DSS engagement, either on a permanent or an ad hoc basis to this committee. And I understand the concerns that you raised, James. I want to just have further discussion about it on both sides. Anything further on Tammy and Susan's open enrollment outreach presentation?
No, we
Okay,
are
thanks,
all-
everybody. Oh, sorry, did I cut somebody off? Go ahead. Okay, hearing nobody, let's move on. Rich discussion. Thanks, everybody. And Holly's passion is welcome. She's not the only one who's passionate on the board. I know that, or on the staff for that matter. So terrific. That passion does inform our discussions and our operations. But moving on to item G, Broker Academy 2023 update. Please go ahead, Tammy.
Yes, great discussion. Let's switch gears really quickly. So a quick update on the Broker Academy. Holly, I'm not sure if you're familiar, but we launched this new program this year, recruiting and training folks from underserved areas in Connecticut to become licensed brokers. So we're wrapping up, we're close to wrapping up year one, right? Our students now are in the mentorship portion of the program. They're almost done with that. Certified, Access Health certified, and ready to go into the open enrollment period, which is exciting. Some of the students will be staying with their mentorship agencies during this time. Some are off to do their own things. But after the open enrollment period, after the mentorship portion of the program, we're not just cutting them loose. We're actually coming up with a plan to maintain that relationships with the Broker Academy students, specifically through our broker support department. So we're working on a plan to keep them engaged, making sure that we stay consistent, and we establish a relationship with them and continue that relationship. So those students are nearing open enrollment, and what's great is we have now 29 new brokers that are from the hardest to reach areas in Connecticut. I mean, we focused on Hartford, New Haven, and Bridgeport this year. So it's very exciting that we have brokers located in those areas now that are from those communities, that know those communities. So huge success for the program this year for us. But you know, we have a lot of lessons learned. So moving into 2023, I know many of you have seen this Gantt chart before. The outline for the chart is going to stay similar, but of course we're making tweaks and changes to each part of the project plan, right? So recruitment, we still plan to start in January, just as we did this year, and that will go all the way through May, right? We are looking to do pre-training, the application process and pre-training classes, right? Getting the students ready before the actual class days in June. And then that starts the training and development portion of the program that will go through August. And then we'll go into the mentorship portion of the program from August to November, which is open enrollment. So the plan stays the same timeline wise, right? We want the students to be ready for the next open enrollment period. So we'll have the class in June. They'll go through the mentorship program, and then they'll be ready for the next open enrollment. So we're still fleshing out the details on each part of the project plan. We have an extensive project plan and workflow that we're working from. And so we're taking those lessons learned from this year and applying it to next year. But I just wanted to let you guys know that, you know, planning has already started for the next Broker Academy class. And we're working on changing a few details in each part of the project plan to make the program more robust and effective moving forward.
Great, thanks, Tammy. I have a quick question. Are we going to be able to track the impact of our first class? In other words, are we going to be able to see how many folks they have actually been able to help enroll, either in the short term or even over a longer period?
Yes, absolutely. So that's the plan we're working on right now. We'll be transitioning those students to our broker support team. We're still working out the details of that plan, but the idea is to have one of our broker support staff really work with the students and provide resources to that student, keep in contact with that student, but we also get the data as well. So any enrollment that happens from the Access Health side, from the exchange, we will have that data.
So Ted,
so we're able to track enrollees by who their broker was?
Correct.
Good. Okay. Thanks, James. Sorry.
Yeah.
So everything that's enrolled, everyone that's enrolled through a broker is attached. They're attached to that broker in our system. So we can run reports to find out exactly by broker or by enrollee. But also we're going to do surveys as well, because they may have enrolled people outside the system in Medicare Advantage or other health programs. So we're going to do a survey of our Broker Academy graduates to find out have they enrolled anybody else and other plans that's not on the Access Health system. So hopefully we have a comprehensive view of how impactful they have been in helping the communities who historically have been ignored by brokers.
Well,
And obviously, there's the economic benefit as well, because they're earning a good living by commissions that they will be collecting as well.
yes.
Kevin Galvin here. I just have a question, if you don't mind. I was just gonna ask, is the compensation enough, is there enough compensation to incentivize these people to continue going after their graduation as they get into and get some experience in the field of staying in that field and us benefiting from their expertise?
So again, this is the first year we're doing this, right? And that's why the mentorship was a big part of the program, getting them established with an established brokerage firm or an established broker. So we want to see how that plays out, but we're going to be supportive throughout the year. I mean, we have people who are dedicated to supporting this team, doing outreach to them on a weekly basis, make sure to gauge where they are, see if they need any help and guidance. And we also through grants, we have a stipend that we're going to give to each of the folks who have completed the entire program, meaning that they've gone through the training, taken the exam, and gotten the license. Because they've invested time in some of their own money. So this stipend is going to help reimburse some of the costs that they have absorbed, as well as give them something to start with.
Great, thank you.
All right.
So one quick comment I would add. Thanks for that question, Kevin. I certainly hope we're going to track their accomplishments in terms of Medigap plans. System-wide, obviously, I have come to support brokers, but they really actually need to get compensated much more for Medigap, or they need to get compensated equivalently for traditional Medicare. That obviously it would be a huge Washington DC lift, but I certainly think that we should be keeping track of their Medigap accomplishments as well. I know the fees are much less, which makes it unfair from the consumer standpoint, because you're not necessarily getting even representation from a broker who gets compensated much more for Medicare Advantage than for Medigap enrollment. But that's just a comment. Cece, I see you have your hand up. Go ahead.
Yes, CC Woods, where is the highest concentration of the new brokers? And can they work across the state, or do they have to work regionally?
So, Sissy, the highest concentration is in Hartford.
Okay.
Right, and yes, they could work anywhere in the state. They're not limited to a particular part of the state.
That's it. Thanks.
And it's worth repeating that most of them are women. Something like almost 70–80% of the new brokers are women.
Okay. Thanks.
And just quickly, remind me, what's the final tally of the folks that are out there and ready to start enrolling in terms of our Broker Academy first class here?
So we have 29 who have fully
20.
licensed, and most of them. And again, there's 29 more folks. Those three communities, Hartford, Bridgeport, and New Haven, last year had none. This year, they have 29 more brokers who live in their own communities, speak their language, understand the nuances of the culture, to help them pick the right plan for themselves.
Good. Great. Cece's hand is still up. I think her question's been answered, but if not, go ahead, Cece. Okay. Anybody else on Broker Academy update? Okay, that brings us to item H, future agenda items. James, I certainly think that this committee probably wants to discuss the wisdom and the pluses and minuses of having some type of DSS liaison to this committee. So I think we should add that to a future agenda item, but I know that you probably have some others you want us to consider as well.
Absolutely. We're going to come back in the future with the updates, with the goals that we discussed. The first item we discussed, modifying, updating the goals, little more detail, more meat on the bones, if you will. So that'll generate more conversation at our next meeting. So we'll take all the input we got today and update the information that we shared and come back to this committee, get further input to finalize where we are. We'll continue to give an update on the Broker Academy, newly licensed brokers that came through the Broker Academy. And again, we'll more discussion around the merits of having a liaison on this committee with DSS, or do we create an ad hoc committee to speak specifically about DSS challenges as it relates to customers?
Okay, great. Holly, do you have any future agenda item? Go ahead.
Actually, I was going to try to get in on the last conversation about the brokers, and I'm so sorry in a way that I talk so much, but I would not be able to live with myself if I did not say this. Medicare Advantage plans are predatory, and it makes me a little nervous and upset that we have trusted members of the community going out into the poorest communities of Bridgeport, Hartford, and New Haven, and pushing Medicare Advantage plans for lower income people. That is really a little frightening for me, because I go to community events and I hear people say how they can't afford to go to the doctor because of their insurance. And then I have to take them off of their Medicare Advantage plans and put them in Medicare and Medicaid. So I just hope that they are really, I'm not against people making money. I just don't want people to make money off of the poorest of the poor people, who shouldn't have money made off their backs, is all I'm saying. Because it's really not cool. It's upsetting for me to hear that they're predatory, and it's known to be predatory. It's national news. So
Yeah.
I had to say that just as a
Yeah.
human being.
Yeah.
So
Well,
I needed to be heard on that. Thank you.
certainly a big part of my role as in the Office of the Healthcare Advocate has been trying to hold the Medicare Advantage plans to account. It really is a big problem. At the same time, at the family level, it can sometimes be an only option, and that's horrible to say, but it is the truth. So we need to work on these systemic reforms. A lot of this is, of course, DC level stuff rather than Connecticut level stuff. Sheldon, go ahead with your comment, please.
Well, in response to what Holly said, I mean, obviously, and both of you, it's obviously a really big issue. And they specifically market to people on Medicaid, and they promise them things that they already have. They entice them with, you will be able to get dental coverage. You will be able to get eyeglass coverage. Yeah, I already have that. So you get nothing, and in exchange, you have a far more restrictive provider network, and God forbid you get sick. That's when prior authorization suddenly is an obstacle to access to care that you don't have with traditional Medicare. But I had a question. The reason I'm saying this, I think I said it last time, but I'm asking Holly, are you saying nonprofits? I mean, I know that brokers are doing it. I mean, they make money. They make, the way, if people don't know, it's a commission. You have, every time you sign up somebody, and this is what Ted was referring to, it'd be great if on the federal level we were able to get payment for brokers so that they get paid either way. Then they wouldn't, right now they have every incentive to not send you to traditional Medicare because they get zero payment. They send you to any Medicare Advantage plan, they get paid. So that's a massive problem. But are you suggesting, when you said trusted community, are you suggesting nonprofits, or is it just the for-profit, broker situation?
No, I'm saying that these new brokers that came out of the Broker Academy, they're being marketed, as I can see, trusted members of the community because they're from the community. That's how I see it, and that's how it's been marketed. So that's what I'm referring to, the people, the 29 people who have come out of this Broker Academy who are going to go into the community and work with a broker, and they get and they sell Medicare Advantage plans in the community. That's what I'm referring to, Sheldon. And then when I go to community events, I switch the people that I see back into regular Medicare. That's all I'm saying.
I'm a little confused by that, but thank you for the answer. I don't want to take everybody's time. But my view, if in fact any of the brokers that are being trained as academy might end up serving the Medicare Advantage pipeline, that has to be stopped. I mean, basically, the training has to include that you will not be involved. You at best be neutral about that whole question about Medicare Advantage plans versus traditional Medicare. That's really problematic if that's happening.
Yeah, well, I mean, brokers make money selling all different kind of plans, Sheldon. So, but I agree with the sentiment for sure. Go ahead, James.
These are new brokers that we have trained, given them access to make a living for themselves and their families. And we specifically targeted communities where there are no brokers. So when folks need help and guidance to pick a plan for themselves that's best for themselves and their families, again, when they are buying a product through Access Health, they're not Medicaid. So they need somebody to help them pick the right plan for themselves and families. The state of Connecticut says you have to be a licensed broker to do that. Right now, this the 3 communities you talked about, there are no Black and brown brokers in those communities. So we developed these brokers, put them back in there. Now, if they partner with an insurance company to sell other products such as dental, vision, or Medicare, or so that's between them and the insurance company that they're connected with. And obviously, we're not in a position to tell them you cannot do that. That's not something we can do. That'd be illegal for us to tell them that you cannot sell certain products between you and the insurance carrier that you're a part of. So,
and again, this is Gerard. All of this has to go through the regulatory agencies, and for Medicare Advantage, that's CMS. They are working about marketing issues on that side, but the start is reporting all of these things and getting the incorrect signups changed back, as you were talking about. And then we work with the licensing of those brokers with CMS and with the local areas to make sure that we're tracking these and to make sure that they are correcting properly in the marketplace. Again, that's where it starts, with the regulation and making sure these things are reported and we can work these things through.
I appreciate that in theory. CMS is doing nothing about this. There is no regulation on TV.
Well, it's not they're doing nothing. It's that they're
doing very little.
They're encouraging.
Yeah. Oh, they're encouraging. I'm sorry.
Encouraging.
They're not neutral. They're encouraging it.
I think it's good for us to keep. I think it's good for us to keep our eyes on the fact that Medicare Advantage has a lot of problems, and we're not going to solve them all in this committee. And in fact, the Access Health Board of Directors is also not going to solve some of these problems. But we do need to keep an eye on it and try to figure out what issues of equity that we can address, are raised. So I urge this committee and the staff to keep an eye on the Medicare Advantage situation and see where we can make improvements going forward. I did cut somebody off in the room, I think. I apologize for that. Go ahead.
I think it was Gerard who's now has to leave because we're just about at time. Right?
No, I was done.
Oh, you were done. Okay.
I got to run to another meeting. I'll see you guys at the next one.
Thank you.
Thanks, George.
all right. Done, right?
Okay, we
Mr.
still have
Chairman,
a couple minutes on future agenda items. Anybody from the committee, and I did cut you off, I know that, James, but anybody from the committee have anything else they want to raise quickly? Go ahead, James.
No, I'm saying that we were completed presentation.
Okay, great. With that in mind, then, correct me if I'm wrong, Marcin, but I would otherwise solicit a motion to adjourn.
That's correct, Mr. Chair.
Okay, is there a motion to adjourn?
Kevin Galvin, motion to adjourn.
Kevin made the
I'll
motion. Is there a second? Who was the
Yes,
second?
Karen.
Karen, okay. Motion to adjourn is not debatable, so we'll move right to the roll call vote. Please go ahead, Marcin.
Theodore Duro,
Aye.
CC Woods,
Yes.
Deb Poland,
Yes.
Sheldon Tubman,
Yes.
Kevin Dobbin,
Yes. Yes.
Karen Siegel, Giselle Corona McDonald,
Yes.
Leslie Greer, and Holly Hackett.
Yes.
Thank you.
Thanks, everybody. I see we're going to have a lively committee, which is terrific. Everybody have a great rest of your Thursday. Enjoy the weekend. I hope people get to see the foliage. It's going to be great this year. It is great this year. Thanks, everybody. Bye-bye.
Guys, thanks.
Thank you.
Thank you.
Likewise.